A fracture to the growth plate has the ability to stop continuous growth to the injured bone, resulting in the shortening of the affected limb and other complications for the child later in life. Growth plate fractures are one of the most common fractures found in adolescents. They account for 20 to 25% of all skeletal injuries in children. The most common cause of a growth plate fracture is blunt trauma. An example would be falling while playing outside. Also, it has been noted that children are involved in competitive sports are increasingly experiencing growth plate fractures due to the physical demands and contact of such sports. The structure of the growing adolescent bone is made up of three parts: the epiphysis, or the growth plate, the metaphysis, and the diaphysis. During childhood, secondary centers of ossification form and enlarge until the entire cartilage skeleton has been replaced by bone. Once the child has reached maturation, all the cartilage will be converted to bone and no longer allow a fracture to occur in the growth plate. Some of the telltale signs of a growth plate fracture include severe tenderness at the affected area, inability to put pressure or weight on the injured area, inability to move the injured limb without extreme pain or discomfort. The growth plate is the weakest portion of a child's bone structure, weaker than the surrounding tendons and ligaments. Therefore, if there was an injury, it would be apparent in the child's behavior and change how active he or she may be. If these symptoms or signs are apparent after a child sustains an injury, medical attention is advised and should be done so promptly in order to avoid additional injury to the affected area or elsewhere. Here is a chart that classifies the Salter-Harris classification. There's a level 1, a level 2, a level 3, 4, and 5 fracture. Type 1. With a type 1 fracture to the growth plate, the fracture tends to go directly across the growth plate without interrupting the surrounding bone. For the most part, these fractures tend to heal rapidly and without any complications. A cast is usually prescribed in order to keep the bone immobile to ensure proper healing. A type 2 fracture to the growth plate starts at the growth plate, but then moves up towards the shaft of the bone. This type of fracture usually only occurs in older children and is slightly more complicated than a type 1, usually involving repositioning of the bone surgically. However, healing time is still fast and complications are rare. Type 3 fractures start through the growth plate and then move to the adjacent joint. This causes concern since the cartilage has been disrupted. These types of injuries almost always require surgical repositioning and casting. If the bone is not realigned, it will cause the bone to stop growing correctly and to become problematic. With the type 4 fracture, the fracture starts above the growth plate, moves through, and then moves to the joint cartilage, which could impair future growth within the bone. Growth plate fractures like this almost always need surgical repair to fuse the bone back together and reposition it. Fractures like this are serious and it may take longer for the child to heal properly. Type 5 fractures have to deal with the growth plate becoming crushed. This type of fracture has the biggest concern since realignment can be difficult. Injuries to this extent can permanently injure the growth plate, requiring later treatment to restore function and realignment of the limb. Occupational treatment. Initially, the occupational therapist's job is to speak with a doctor or a surgeon about the severity of the fracture so that a plan can be implemented that will best benefit the patient and his or her needs. Depending on the fracture, range of motion exercises may be prescribed to help strengthen the muscles surrounding the affected area in order to keep the joint moving the way it's supposed to. If the fracture was too severe and growth was stunted, it's the occupational therapist's job to work with the child to help improve functional ability, especially when performing ADLs, helping the child adjust to his life changes by teaching them new techniques to help them function in their day-to-day life. In most circumstances, a patient usually has a cast or splint after a growth plate fracture. A cast or splint ensures that the fracture can heal properly without movement to the affected limb. Whether or not the patient has a cast or a splint depends on if the doctor has to surgically repair the fracture or not. If there is an open wound, a splint will be used in order for the doctor or occupational therapist to keep an eye on the incision. The occupational therapist also needs to deal with the psychological aspect of this injury as well. Having a deformity can be extremely detrimental to the psyche of a child, and these issues may have to be resolved before any progress can be made physically.